Just started the recording. All right.
All right.
Now I'll share their screen again.
There we go. All right. So we will start this party. Welcome everybody. My name is Leslie and I am the president of the Northern New Jersey chapter of HPNA. And this is our first quarter meeting of 2023. And we are so happy that you are all able to join us. And I'm hoping that you will really enjoy and be able to participate in this interactive presentation that we have tonight for you. We found when we did our assessment tools, we used our assessment tools earlier in the year last year about topics that our members and followers might want to see, and this was a big topic that people were interested in. And you know, I know for myself, pediatric palliative care is a foreign subject for me. So I'm very excited to be able to be part of this great presentation. I'm just going to give you a brief overview of our chapter status. We have our education plans for the upcoming year. We have a bunch of educational programs that we're planning. Donna Fahey is our education chair, and we're going to have two live events this year in 2023. It'll be our first live event since we first met in 2019. Right before the pandemic, we became a group that became a chapter in 2020. So we're going to have a bowling event, and we're also going to have a chapter dinner at the end of the year. For our secretary report, quickly, our chapter meeting minutes are posted on our Nursing Network site. And then just quickly, our treasurer report is we have our current balance is $1,417 that we've gotten a lot of money from sponsors as well as donations. And so thank you all for you who donated. I'd just like to introduce our committee chairs and board members. I'm not sure if, I know Melissa is on, and she is our president-elect and secretary. I think she's on.
She is on. She's not on video.
Okay,
sorry.
That's okay. That's all right. Well, Melissa is our president-elect and secretary. And we have Ryan Murphy, who is our treasurer and the chair of our membership committee.
You said no.
We also have Adrienne Alate, who's our IT and media, our media chair. She's not able to join us tonight. And Donna Fahey, who I've already introduced, she's our education chair and planning chair. Stacey Rifkin-Zenenberg is our immediate past president, but she's not able to be with us tonight. She's living her best life with her family in Israel right now in her retirement. So we're happy for her and we miss her. And so basically, you know, that's kind of it from me. I want to just really thank you all for being here. For those of you who donated, for those of you who, you know, have the opportunity to join us in our future events, we are really happy to be able to present, you know, continuing education credits, which Donna is responsible for. So we're very grateful for that. And I'm going to turn it over to Donna, and she's going to take it away. She's going to have a poll for us, and she's going to introduce our speakers as well as go over a few housekeeping items.
Yeah. So I'm going to save the poll because I'm going to have to switch between PowerPoint. So I'm going to squeeze it in there. So just a couple housekeeping items. If you want to say hello in the chat, we have a question for you. What's your favorite thing to do in the winter? It really hasn't been a winter in New Jersey. It's certainly been one in California, which is really bizarre. But if you want to just share what your favorite thing to do in the winter as a just a get to know me question. So as you know, the webinar is being recorded. We will be able to provide the link on our Nursing Network page for you to watch as well. If everybody, once we start, can mute their your microphones, that would be great to reduce the background noise, but you'll be able to communicate with us either through the chat or through the Q&A box. And we hope to have time at the end to have a discussion afterwards. For your continuing education credits, most of you have registered with your name and your email, but if you could just confirm your attendance here tonight in the chat box and put your full name and your email address, I'll be able to copy that at the end of the evening, and then that will be our distribution list that will send you the information. So you'll be getting an email from Relias Learning, which is our platform that we do our education through at Samaritan. So it will give you a link to log into Relias. You'll complete an attestation form, which basically says, yes, I was there and I watched the education. And then you'll complete an evaluation form. And once you do those two things, you'll be able to print your certificate directly from Relias Learning. We ask that you complete this by the 24th. So that's 2 weeks from today. And if you have any questions, my email address is on the bottom there. It's institute@samaritanNJ.org. We'll help you through the process or answer any questions that you have. So our learning objectives tonight is that we hope by the end of this activity that the participants will be able to dispel common myths and misconceptions about pediatric palliative care, to identify at least one tool or technique to support the care of pediatric patients and their families. And also, most importantly, we hope that you'll be able to care for children with serious illness with confidence. We have a couple tools and resources that I'm going to be popping into the chat for you. These are coming from the pediatric e-journals from the National Hospice and Palliative Care Organization, NHPCO. We selected 5 for you that we thought would be good targeted education. So I'll be popping those to the chat during the discussion so that you can download those and read them. But if you don't have a chance to go into the chat, this is where you can get all of the e-journals from NHPCO. They're free and you can read them. They're kind of nice. They have sometimes case studies and some pictures, and it's just really relatable information that I think can be applicable in the clinical setting. So our presenters tonight, Stacey Rifkin-Zenenberg and also Karyl Reid, they have no conflicts of interest. They have no commercial support. They're not going to be talking about any kind of non-endorsed products or talk about anything that's off-label use for medicines. Now, it gives me a great pleasure to introduce our fabulous panelists, which we're so excited, and they're just fantastic people. So we have Dr. Stacey Rifkin-Zenenberg. Stacey is the section chief for pediatric palliative care at Joseph Sanzarine Children's Hospital at Hackensack University Medical Center since 2016. And she has been the pediatric medical director of VNAHG, formerly Barnabas Hospice and Palliative Care Center, since 2003. She also participates in teaching medical students, residents, nursing students, APN students. She engaged in bedside rounding and office palliative care in her free time. We also have Karyl Reid, APN. Karyl is an advanced practice nurse for pediatric pain and palliative care at Joseph M. Sanzarine Children's Hospital at Hackensack University Medical Center since 2019, and in pediatric emergency room, ED, since 2002. She is a clinical preceptor for pediatric and family APN students and participates in teaching nurses, nursing students, residents, and also engages in bedside rounding and outpatient pain and palliative care. Now I'm going to switch my screens. We're going to do a quick poll. All right, here we go. All right, there should be a poll on your screen. If you could answer these questions real quick and pull some results. Is it working for you guys?
Are you able to answer the questions? No?
No?
In the chat.
Yeah, I am.
Okay.
Yeah.
Yep.
Mm-hmm.
Okay. Oh, I see him moving. Okay, good. Yep. Excellent. Okay, we'll give a couple more minutes and then I'll show the poll.
There's the wheel. What your wheel looks like. Oh, yeah.
Okay, we've got about 9 people that answered, so 64%. So these are just some teaser questions to hopefully engage your curiosity. So I'm not going to give you the answers. We're going to retake our poll at the end and see if our things have changed. I am going to save it for prosperity. You can see the results, right?
Mm-hmm. Yes. Mm-hmm.
Okay. All right. And then we'll kind of go over them at the end. All right. So now I am going to pull up the other PowerPoint. Give me one moment. Show from the beginning. All right. Are you able to see the PowerPoint?
You know.
No?
Yeah,
yes.
we can.
Okay. All right.
Yes.
Let me just
you have you off mute.
Find my presenters here and spotlight them.
Mm-hmm.
Let's see, where are you? There you go. It's going to spotlight you guys. And unspotlight me.
Okay.
There you go.
You see
All
us?
right.
Okay.
Take it away.
Okay. Hi, everybody. We're going to talk today about pediatric palliative care. Do you want to go to the next? So we wanted to talk about pediatric palliative care as it is a little bit different than adult palliative care. Ours is really a continuum of supportive care. It really starts in utero. We actually meet many of our patients when they are in utero. We have a fetal care center at Hackensack, and we meet our patients sometimes in the fetal care center when babies are diagnosed in utero. So we meet them with our maternal fetal medicine patients. And that's when we can do our birthing plans. So sometimes that's when we meet them with our neonatal palliative care folks. And sometimes in the most perfect world, then the babies would be born with a birthing plan, and they would go to our NICU, and then they would maybe be discharged from the NICU, and then we would take care of them outpatient, and we would go through different goals of care talks and maybe kind of move towards complex care issues. And it would be a whole continuum, but that's not really what happens because it's not a perfect world. And we don't always get involved in the beginning, which would be the best possible scenario. But that's really the continuum of supportive care that we actually see in pediatric palliative care, because it's a much different world than adult palliative care. So really, we interface with obstetrics and maternal fetal medicine, pediatric subspecialty care, neonatal, surgical interventions, and complex care. So we really bridge this entire group of people. Next slide. So what is the World Health Organization definition? So it's really an interdisciplinary approach to improve quality of life for all children with life-threatening and life-limiting conditions, and for really prevention and relief of suffering, regardless of the stage or condition of the disease. And we look at the physical, the psychosocial, the spiritual needs of the family, and really today's topic is to look at really palliative care plans, you know, looking at goals of care, looking at symptom management, including pain, and really end of life care, because we do all of this. It's not just end of life. It's really looking at all of these in entirety. Next slide. So I think that one of the things that was asked of us was really, what are those differences between adults and pediatrics? And I think even within pediatrics, we see a huge you know, diversity between cognitive abilities and emotional maturity between, you know, babies, toddlers, school-age kids, adolescents, and adults. You know, even within parents and the kids, even the parents themselves, with understanding what is going on and the emotions between the parents when we have children with different diseases and illnesses. So I think that it's really very difficult to really to look at the dynamic of palliative care, pediatric palliative care, and really having that whole dynamic of having the parents, the kids, and the adults. I think the etiology of life-threatening illnesses in children are very different than what we see in adults, because a lot of our life-threatening illnesses in children are either congenital, they're genetic, they could be things that parents carry and give to their children. So there's a tremendous amount of guilt that is carried by the parents. It could be because of something that had happened, especially in utero, that could be caused by the parents. So I think that those are some of the things that go along with pediatric palliative care. I think when you look at the dynamic of the triad versus the dyad, where you may have two parents or two guardians or two whoever the caregivers are, and then taking care of the child, you usually have that triangle, whereas in adults, it may be just the patient and a spouse, the patient and a child, the patient and the caregiver. It's a whole different dynamic than what you see in adult palliative care. And then the other real big difference that we have is you have a non-autonomous individual in pediatrics who is not necessarily making decisions versus an autonomous individual in the adult world. Although we include the child and we want the child to assent to things, and we want the child to be involved and to have some type of shared decision making, they don't really have to be the decision maker per se, as we do in the adult setting. Next slide. I think that the top of this picture, the series type of this was when I first started doing this 20 years ago, is how we used to think of palliative care, where we weren't really called until the curative approach was done with and there was nothing else to do. Then they kind of called and said, hey, could you come, because there's nothing more to do and I think you need to come then. And the patient was 5 minutes away from dying, and that's when they wanted me to come. And then, you know, then people started thinking, well, maybe we could call you, you know, when we started having symptoms, maybe you could come and help in the and do this concurrently. So then it was more of a parallel kind of thing when the diagnosis was made. And maybe it made more sense for you to be a little bit part of the team. And maybe it wouldn't be so great to introduce you as a new player closer to death. But you know, what makes more sense, and what there's a big push in pediatric palliative care, is to really integrate the pediatric palliative care team closer to diagnosis, because early integration really makes a big difference, because then that team is part of the team and it helps the families to really make great decisions and about values and their standards and goals of care to and it really helps to be the glue between all of the services and to really support the families. And there's a lot of literature to support this in pediatric palliative care. Next slide. So some of the unique challenges in pediatric and neonatal care is, like Dr. Rifkin said, we go from prenatal care to neonates all the way up to the age of 22. So there's a wide range of ages and developmental style. For staff, for ourselves, like you're continually exposed to both children who are ill, some seriously in pain, possibly dying, and to their families who are also suffering. So like Dr. Rifkin said, it's the dyad versus, and the triad versus the dyad. So we don't only take care of the patient, but the entire family. Illness or injury can be congenital, genetic. We have a lot of multi-complex patients who have a variety of medical conditions. Could be trauma, either accidental or deliberate, life-threatening, life-altering diseases, self-inflicted. So it really runs the gamut. You know, family members different in their members. You know, we have, you know, a mom and a dad and siblings, or we can have a mom and a mom, a dad and a dad, you know, two families, grandparents, extended family, that we all deal with. And they also cope with stress and illness in different ways, and they have differences in resources available to them. You know, every family member is affected by the illness or injury. So we have to take that into account. The varying ages and developmental levels play into it. You know, the individual need versus the parental or family needs. So, you know, we have to, like Dr. Rifkin said, if children are younger, they give their assent if they're about 8 or 9 or older. But, you know, the teenagers, young adults can have thoughts in one way and goals of care that may be different from their families. And so we work with them so that they can kind of get in a similar goals of care. There can be abuse and neglect. Drugs and alcohol can play a part. The moral distress, not only for family members, but for the entire pediatric team that's caring for the patients. And then community involvement. So the school, the friends, neighborhoods, you know, kids are on teams, they have jobs, religious, law enforcement, and child protective services. So we really interact with pretty much everyone within that family and community. Next slide, please. Again, you know, the unique advantages that I've always found, I've worked with adults, but, you know, the majority of my career is with pediatrics, is the interactions we have with patients and families. And for a lot of us, like Dr. Rifkin said, if we start right from the beginning or involved early, we do have a relationship with the patients and families, and we've seen them grow over time. You know, kids keep you young, they're very inquisitive, and you learn to explain things on different levels, on their developmental level. We learn a lot from our kids. Even the youngest kids know, especially towards end of life, that they're dying or that something different's happening. And, you know, they'll ask you questions, or you help families and how to have that discussion. Kids are very honest, sometimes too much so, but, you know, it keeps us on our toes. You learn patience, not only with the kids, but with the family members, and taking people where they are at that moment. We get a different perspective, not only on life, but on death and what they go through, the resiliencies of our patients and our families. Also hope, right? Because sometimes there's a diagnosis, maybe in the NICU, that, you know, this child, you know, is not going to live more than a few months. And here they are at 18 or 19, still alive. We have to use our imagination a lot, all of us that work in pediatrics, because you have to come up with different ways of doing things, and it's never routine or boring, because no family No child is ever alike, and the situations, I think, even change on a daily basis. Next slide. The one thing that we have in pediatrics up to age 21 is concurrent care. So even if children are on hospice, there still allows for curative treatments to target the underlying disease. So we can have kids that are on hospice care that may still be getting chemotherapy, and it's not just palliative. They can get dialysis, they take their anti-rejection meds. And then while they're on palliative and hospice care, you know, and while they're getting concurrent care, they can also have palliative and hospice care where they can, you know, work on symptom-based physical symptoms, spiritual, psychosocial, and cultural considerations at the end of life and during the whole palliation while they're going through concurrent care. Next slide. One of the things that, you know, we all deal with is moral distress. You know, when a practitioner feels certain of ethical course of action, but is constrained from taking action. So often we may have that. We have a lot of team meetings because, again, it runs the gamut. You know, sometimes there can be multiple teams involved in each patient. You know, and families may have, we can have some moral distress from families' decisions of their goals of care, which may not align with ours, but we have to remember that no matter what, it's these families that have to carry on after, especially if a child dies. And so, you know, we go home the next day and we may remember the child in different ways, but the family has to live with that. So we try to work not only with ourselves on moral distress, because as a team, we talk a lot, but also with the rest of the staff, with the ICU staff, with the oncology staff. So we work a lot with the staff members that are involved. And then, you know, we look at situations that involve ethical dimensions and dilemmas when the individual feels he or she is not able to preserve all interests and values at stake. So sometimes a parent may want to keep a child alive when we know that it's futile, but how we work with the family and work within the constraints we have. Next slide. Also, you know, when dealing with moral distress, we talk a lot about self-awareness, like how we're feeling, how, you know, sometimes we discuss with the staff taking care of the kids if they're still, you know, inpatient, even outpatient. We've often, Dr. Rifkin and I and Mary, our social worker, have worked with home care nurses who take care of some of our kids in regards to moral distress and the self-awareness of where it comes from. Self-care. We are a holistic team, so we're very big on self-care and doing what works for you, as long as it's, you know, not detrimental. You know, part of our team, we have a music therapist, an art therapist, we have a social worker, you know, so we can focus on self-care not only for the patients and the families, but for ourselves. You know, focus on the changes in the work environment that preserve moral integrity. So what we can do to support each other. And then, you know, like I said, there's 3 levels of the intervention: patient care, the patient, the family, the unit, the team, and the culture, and also the organization. Next slide. So we thought we would talk about a case study and you know, I guess if anybody wants to, you know, ask any questions, they can definitely ask some questions about it. We have a few time points during the case study. This is actually a real case study that we took care of this patient, and it's a 21-year-old with severe cerebral palsy and an intractable seizure disorder. And tracheostomy dependent, gastrostomy dependent, wheelchair bound, and was taken care of at Hackensack since birth. Born at 21 plus weeks, ventilator dependent at birth, had extensive respiratory disease in the NICU, and had intracranial bleeding, grade 4, which means that it's the worst type of intracranial bleeding that you can have. Had seizures, VP shunt placed in the NICU, and had a prolonged NICU stay. What the family had told us was that there had been extensive family meetings about goals of care in the NICU, including withdrawal of support. But this had been a child that they had waited for a long time, and they had no other children, and this was not an option for them, and they loved this child. So they decided to never withdraw support and actually forged on. The goals of care were that even though they weighed every option, they always were very positive, and they always had hope in every single family meeting. And they always were very interested in not having their child suffer, but they were very positive. Next slide. So then we fast forward. I don't know if anybody has any questions, but so then we fast forward to the teen years. So as we kind of, as this child grows, he becomes the patient of many subspecialists at Hackensack. He has, multiple admissions, and he sees multiple subspecialists. He is on room air at this time. He doesn't have the trach yet, but he has multiple admissions. He's on room air. He's not needing any respiratory support. He has a G tube, gastrostomy support, because he's had it since birth. He has a seizure disorder. Has had multiple revisions of the VP shunt, which is normal. Okay, so typically, just for everybody to know, when you get a VP shunt in the NICU, it is not uncommon to have somewhere between 20 and 25 or more revisions of your VP shunt. I know that sounds kind of crazy for people who are not pediatric on the call, but it is. Each time when the family, and these are, some of this is from what the family has told us. Each time, sometimes a staff member, and sometimes Karyl, some of this is from Karyl, because Karyl worked in the ER for many years. Sometimes a staff member would whisper why when they would come in for a revision of the VP shunt. But also had multiple admissions for aspiration pneumonia, because the child would seize and aspirate and then get aspiration pneumonia. The child goes to a special education school, goes to Disney World every year with his parents, because this is the favorite place for the family. And when the parents are asked, they feel he has a great quality of life. He also has a service animal, which comes to the hospital with him. They have it, and the parents have developed a way to understand a language of communication that with this child, and he is included in everyday life and their everyday life. The way that this child communicates, most people don't understand when the child is brought to the hospital. Okay. Any questions? No? Okay.
He also, most, I would say, a great percentage of the staff, from the ICU to our EMU to the ER, even on the peds floor, knew him, and most of our physicians knew him over the course
of the 21
years.
So most people have taken care of him in pediatrics. So,
I'm going to take the liberty to ask anyone, if you have any questions, feel free to unmute yourself and just ask the question.
So in the last 2 years of his life, so it's about year 20 and 21, he's had multiple admissions because he's having more and more issues. He has multiple admissions that are leading to intractable sepsis. Oh, hi, Cheryl. Cheryl and I know each other for a long time. Wait, what did Cheryl ask?
She said it's not about what you think you would do in the same situation. It's their journey.
Yes, 100%. So what happens in the last 2 years is that so we're on this journey with this family, and you know, we talk with them a lot and about a lot of the things that happen. And during these last 2 years, the parents make a very difficult decision where they never wanted the trach. And this is the time that they decide to put the trach in, because they decide that they didn't want to have it because they felt that it really would cause more suffering. But they decide, after having long discussions with Karyl and myself and the pulmonologist who's taken care of him for 20 plus years, that they decided that he needed it. And he very quickly, after getting the trach, becomes ventilator dependent, actually. He first is not ventilator dependent and is on room air with the trach, but immediately gets a few bad infections and becomes ventilator dependent.
A lot of increased secretion.
And he has a lot of increased secretions. And even though we try to control them, he becomes ventilator dependent. And then he then starts having pain, and the parents, you know, we try different ways of controlling the pain, and we actually start talking about different ways of different modalities of pain management. And in the interim has this intractable sepsis that's refractory to all antibiotics. And it really, it's what's happening is all the subspecialists are talking to Karyl and I and saying, what's going on? What's going on? And I'm saying, I think we're saying we think he's moving towards, you know, end of life. And they say, no, we can't do this. And we say, but this is happening. What happens is, at this point, the family reaches out to us and say to us, we think it's time for hospice. So we knew it was coming, but they actually approach us, and say to us, it's time.
And that was after multiple discussions over the years about goals of care and transitioning, and they were never really ready until this time.
Yeah, that he had chronic, he had pain, and they said it's time. He's tired. We've done everything. We feel like, hi, Susan Lindsay. Agreed. It was a long discussion, and he was put on hospice with a great hospice team, who some of them are on the call right now, and he had great home care nurses that had been with him for many years, who had hospice, who actually used to work in hospice also, the home care nurses that he had. But the hospice that we used and the home care nurses were there. And I actually went over to their house and terminally extubated him with his family there. And it was very hard. But this is what the family wanted, and his dog. So it was a really difficult situation. And I think it was very difficult when I came in and I told everybody. Because the staff, it was very difficult for also.
Yeah, after years of everyone kind of questioning sometimes why all this was being done, you know, and for the parents, because the parents became friendly with a lot of staff because he was there so often.
Yeah.
And they did have some family disagreeing with their options, right? And their choices, actually, the choices they made.
There was family, they had family who disagreed also, that we had to kind of support the parents, because they had extended family that really disagreed with their decisions.
Their choices, like the trach and then end of life.
Yeah.
So Dr. Rifkin, there's just, a couple of comments here from Susan Lindsay. She said, beautiful illustration of focus on highlighting the person, that family knew when quality of life was being impacted and guided transition to end of life. You really trust over all these years.
I think that she's right. I think that the parents really knew their child. I mean, these parents were so connected to their child and so in tune with their child and knew his suffering. They were so, they were in tune with each other, and they were in tune with their child. They totally understood when enough was enough, and they also supported one another tremendously. They really could tell us, when they really
expressed themselves well, both their emotion and what they felt were their wishes for Josh. And at each point, and they would advocate for him, even when, over the years, it'd be these discussions like, why are we doing this? And the parents would say, because he's still fighting, he wants to do this, and he has a good quality of life. And, some of our parents are like that, and families, some go through the transition, the process differently. But it is true. You have to look at each individual patient and family members of where they're at and kind of work with them where they're at.
I think there's also another unique thing about this specific case. The other unique thing about this case, which, I think that we see this in adults also, is that, this patient was cognitively, was thought to be cognitively impaired, okay, and definitely was not verbal. So the thing is that he had a way to communicate, okay, and you had to talk to the parents and really understand how to communicate with them, okay. And I think that was another thing that these parents fought for. They fought everybody and the system to say, this is how my child communicates. If you're going to talk to me, you need to communicate with my child this way. So that was the other kind of thing that was very unique with this situation. And you had to do this.
Can I jump in there? So I just want to share, this is Leslie, that I have such a similar experience. One of my dearest friends and his wife struggled to get pregnant. They adopted a child who was perfectly healthy until he turned 2. He developed a devastating neurological illness, and he basically went through the same journey. And I was going to ask about the communication, because looking at them, they also feel that he is completely able to participate in the conversation, that he's completely able to comprehend what's happening. And I, would never take that away from them. The difficult part for me is that they struggle so hard with removing themselves from being kind of managing everything that goes on. The father is a pediatric nurse practitioner. The mom is a, you know, a PhD in education. So they kind of took all of their knowledge and just kind of micromanaged his care. And so my question to you would be, how were the parents able to be parents? Like, did they have the support to be the parents, or were they kind of in a position where they had to, you know, do a lot of the medical part?
I think probably both. And I think that's with most of our families, because, you know, they, especially, you know, when they're home, like a lot of times when they're in the hospital, we'll talk to families. And, you know, even when I was a bedside nurse and stuff, we'd talk to families about, this is kind of your respite. We'll do the suctioning and you just be mom or dad. But for all of our, I could say all of our families, they have to be both, because even though they have home care nursing, they don't have it 24 hours. Like, you know, nobody's getting that. And there's not home care nurses. So they do have to be the caretaker and also the parent. And, you know, I always tell parents that they know their child better than any of us do, right? And so they have to, you know, let us know what's going on with their child. You know, sometimes we have to point out things like and say, oh, well, is this happening? But I think that's the one aspect in pediatrics that we always have to tell people and keep in mind, is that that's their child, and they are probably, they are the expert on their child. And how can we help them with it? But there does get parents that we've had parents that are extremely micromanagers, that are angry if people don't do things exactly their way. And it's just, you know, talking to them and say, look, there's different ways of still doing the care in the right way, that's sterilely or the way to suction. Just because you do it this way doesn't mean that everyone's going to do that way. And so again, it just takes sitting with the parent, talking to them, and kind of seeing where they're coming from. Because a lot of parents, you know, I don't know, sometimes there's some guilt involved. Sometimes they've been their advocate and, you know, the protector of their child for so long that they, not that they don't want to give up the control, but they can't. But most of our parents, once you just talk to them and sit with them for a while,
a lot of them have a lot of them have never had someone say to them, how can I help you?
Yeah.
And I think that I think that is what a lot of our patients who have medically complex kids have never really had that. They've been talked at and told what to do, but nobody has ever said, how can I help you? What do you need? You know, and I think that's, you know, or what do you think about this? You know, what do you think is going on? Or, you know, so I think that's, you know, I think that's part of the problem.
I really struggle as a palliative provider, knowing my place. You know, I don't know if either of you have ever, but you know, I had to do exactly what you're saying and say, how can I help you, rather than, you know, sharing my medical knowledge. You know, and another question I did have for you, though I don't mean to monopolize, but how do you deal with the trauma that comes with these experiences? Because I see the trauma that, you know, my friends went through, doing CPR on him in the ICU, you know, bringing him back and forth to the hospital with all of these infections, and that trauma. How do you deal with that with the parents? So,
you know what? So it's interesting. Many of our parents, we actually, a lot of them want to see it. A lot of them want to be in the room. We do give them access to see it, but it's really important to have somebody standing next to them and kind of talking them through it. It's important that they see it. It's important you have someone talking them through it, like telling them, this is what's happening. This is why they're doing what they're doing. If they don't want to see it, that's okay, but at least giving them access to see that things are being done. Because I think that a lot of parents want to be able to know that everything was done if they want it done. I think that should they not want it done, obviously they should have the option to say, I don't want CPR done and I want to allow a natural death on my child.
And I think the other thing too is that grieving starts either from the moment of diagnosis, from the injury, from the birth, like, so it's you know, the grieving process is going on. It's, for some families, it could be, you know, years, it could be months, it could be, you know, a tragic, you know, injury or something, could be a few hours. So I think, you know, with our team and with social work and you know, the pediatricians and all the other team members is working with those families through that whole time and going through the grieving. And a lot of our families will say, like anything, right? It's a roller coaster, right? You're on a high where they're doing okay, and then, you know, the next day they're not doing. So I think it's just kind of working with them where they are at that point in time.
So I just have like a piggyback on that question. There's a question here. It says, in adult hospice, we are often faced with the ethical challenge of the family not wanting the patient to know that they are on hospice. Do you find similar challenges with pediatric palliative care, where the child does not know what is happening and you feel that an ethical desire to talk to them about it but can't, because the family or the parents do not want you to talk to them about it?
Well, I've only really had that happen once in like the 20 years that I've had it. And it was like the single time that I've only had it happen. And I've never let it happen again. And it was because the family would not let me put the kid on hospice any other way. And they agreed to have me put the kid on hospice only that way. Otherwise, every other time I've actually, and it was like a teenager who couldn't get out of bed, and the father was like lifting the kid up physically and the kid was like paraplegic because of a metastatic cancer. And I was like, this is ridiculous. Like, you have to let us do this so that you have services in your house. Like, and the father was like, and it was like a kid that I was treating. And I'm like, seriously, this is like the most ridiculous thing ever. And the family was fine with it, but they're like, you can't tell my child that blah, 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 and whatever. And the kid was so close to like the end. I was like, fine, whatever. Like, if you say, okay, and this is how it has to be, whatever. Otherwise, no, the answer is no. I mean, we do it. And most of the time the kids know, and I'll be honest with you, I think that the adults know. So I think that it's like a whole lot of like nonsense that the adults don't know, that you like hospice is coming in, that like new people are coming into their house if they're on hospice. Like, who are these new people coming into my house?
Yeah,
like,
I think, yeah.
Really?
And I think,
yeah, Stacey, it's Ellen. I feel like my years doing pediatric oncology, hematology, the kids were remarkably aware of what was happening, and also sometimes extremely protective of their parents.
Yeah.
Worried about their parents, wanting to talk to you about what will happen, but not feeling mom is ready yet.
Yeah.
And then you being in the situation of trying to help the parents understand to start the conversation was usually my experience. So it's really an interesting question, but when I think about it, I agree. It's almost the opposite.
Yeah. I mean, usually, I guess, like as a pediatric oncologist, I've had more conversations where the kids have pulled me aside or pulled like some of us, like one of the group in pediatric oncology, whether it's like a social worker, a nurse, child life or something, and said to us, like, listen, like one case I can tell you, I had an 11-year-old who had, who the mother just looked at me when I said, I think she's relapsed. And the mother looked at me and said, I cannot tell her. You have got to go tell her. And I grabbed my child life person and I said, okay. And I went in the room and I looked at the kid, and she was a really adult 11 or 12-year-old. And I walked in and I go, listen, I have to tell you something. And she goes, I already know. It came back, didn't it? Because she had petechiae everywhere. And I said, it did. She goes, all right, so what do I have to do? And I go, well, you don't want to come in the hospital, right? And she goes, no. And I said, so if I have you to be at home and I have my friends from hospice come who, you know, could come and visit you at home, you want to be at home with your mom and your brother? And she goes, yeah. And she goes, what does that mean? I go, well, what do you think it means? She goes, I'm going to die from this, right? And I said, yeah. And she goes, okay. And that was the discussion that I had with her. And that was it. And because the mother was like, I can't do this. And like ran away from me and just said, you've got to do this. And like, that was it. And she said to me, so then I said to the kid, well, what can I do for you? And she said, I want you to make sure that my mom is okay after I die. And that's like, that is what happens with kids. Like Ellen is right. Like the kids are unbelievably like resilient and are worried about their parents, and like either will worry about their parents. Many of them will want to write a will and will their stuff away. I mean, it's very interesting.
I think it's also, you have to see where the kid's coming from, because sometimes like they may ask a question and we want to give them this big long answer, but like I usually put it back to them like, why are you asking? What do you want to know? Because sometimes it's very just simple and it's not what we think they're asking. But just like, you know, we're always honest with them. We tell parents, if, you know, parents like, don't say this, don't say that. It's fine, but, you know, for certain things, but we tell them if they're going to ask us straight out, we're not going to lie to them. We're going to be honest.
And I think it's the same thing with adults. I mean, I think if a little old lady who is dying of cancer or is, you know, has end-stage heart disease or end-stage emphysema and is huffing and puffing, they got to know that this is what they have. I mean, like, I can't imagine that they don't know that they're getting worse. You know, I mean, really? You know, when their child says to somebody, says to you, don't tell them they're going to lose hope. Like, it's kind of weird that to me that really, like, they don't know they're declining. They can't walk down the street like they used to, or they can't walk up it's hard for them to get to the bathroom. Like,
yeah, or we just say like, we're going to change the hope to a hope for no pain. I can say every single parent, their biggest concern is that their child doesn't suffer.
And I feel like that
they want to make sure that their pain and their symptoms are controlled.
And that's what I mean. I think that is the same thing for adults. Like, it's not that we're not taking any hope away. Mm-hmm. The hope is just changing.
Yeah. It is so true. I think, Adrian, do you have a question? You're muted, Adrian.
Okay, thank you for that. No, I do have a question. And so it sort of piggybacks on what Leslie asked as a medical question in the medical field. My question was, as an end-of-life doula who focuses on the emotional, mental, and spiritual side of people and how they show up, I wanted to know, like, I wanted to know a little bit more about the parents, right? Like, where did that alignment come from? What was their, was there a higher power? Like, what was that allowed them to show up and be in such an alignment? Maybe it was just going through the birthing canal. Like, can you speak anything other than the points that Leslie made as far as education and being in the field that allowed them to show up and, really map out a perfect life for their child?
These parents, I think, are two of the greatest people in the world, I think, that I've met. I think Karyl would say the same thing. I think that they're
They're always very positive.
Yes.
They knew what was going on. They read, you know, they weren't in the medical field, but they read up on things. They asked a lot of questions. I think they were spiritual, right? Like they had a.
They definitely were very spiritual.
They relied on their religion and their religious community.
Yeah, and they were they had a very good connection with their spiritual leader, and they were very much
they were positive, but they were realistic, right? Like,
yeah,
you know, when he wasn't doing well, they understood it, but they tried to remain positive. It wasn't that like they weren't in denial.
And I think that their feeling was that they knew he wouldn't be with them forever, but that the amount of time that he was with them was going to be very special and would be, you know, very precious to them, and that they really cherished every moment like it would be with them forever. And I think that both of them were very connected to that feeling. And I think that's, you know, they both felt the same way about it, which I don't think that, you know, when we meet parents, like they don't necessarily grieve on the same wavelength, you know, all the time, but they really did.
I do have to say that again, I'm referring to my friends, but it was exactly the same thing. You know, his mom said to me when he was newly sick, you know, I was trying to support them through this anyway. She said, I just want him to have one moment of joy each day of his life. And that's how they've lived with him for his entire life. And they continue. A couple of times they've asked me, you know, what do you think? And, you know, I've been honest with them and I've said, you know, you just kind of have to think about when these things that we're doing are no longer acceptable to you for him. You know, like I tried to be as, you know, cautious as possible because I don't want my palliative, you know, role to spill over. But, you know, this redefining hopes is amazing. Susan Lindsay in the chat says, you know, helping to redefine hope is a skill, and it's one of the things that I
but I guess
I say
but you know what, here's my question. Can't your palliative care also be like our palliative care, like the concept of, you know, like creating hope and like good quality, you know, like a positive, you know, kind of creating great quality of life and you know, that kind of thing. I mean, that's what we're doing for kids and for families, and trying to kind of be the glue between the, you know, services, and trying to create whatever we can to help, you know, families navigate the health system.
Yeah.
You know, that's really what we're trying to do. Yeah.
I think just to kind of answer that, I think one of the barriers that we kind of come up against, and this is coming from that hospice side. I'm not in palliative care, more on the hospice side. We'll get, and I was an inpatient manager, so we would have the sick patients coming from the hospital that were dying. And it's almost that, believe it or not, they're angry that the health system hasn't saved this person's life. They don't believe that the person is dying. And, you know, it's so bizarre, because you would think that over someone with a chronic disease that's had it for over 20 years, they, you know, they would have some awareness that, you know, life is not infinite, it's finite. But yet there's so much denial, there's so much complicated grief in this adult population that a lot of times we're even in the inpatient center, don't tell them. I said, but it's written on my shirt. You know, and, you know, it's just this crazy way of them trying to have control over something they have no control over. And it's bizarre. It really is a kind of a bizarre thing, but it happens a lot. And, we'll try things like, trying to specify what, let's talk about the moment. Let's not talk about the whole picture. Let's just talk about the next 2 hours, and I guess that's kind of a way of redefining hope in a sense. What can we accomplish in this 2 hours that will make so-and-so more comfortable? And then we'll just tackle that for right now. But it's bizarre.
Well, I mean, I think that, I think that it's very similar to like all of these. I mean, I think that's very similar to kind of the 2 hours is very similar to like the 365, 24/7 that our patients go through, right? Because that's really what most of our families go through, right? There's no respite.
Right.
So just that little moment in time that they can have a little tiny bit of respite. So that just those moments of joy, right?
Yeah.
So.
Anybody have any questions, comments, concerns? No, just kidding.
I have one more thing to say.
Sure.
So I'm going through a very challenging life, like personally now. Lots going on with my daughter, my father-in-law, my husband, you name it. And I chose to be an end-of-life doula. I walked away from a job making extremely great money, $5 co-payment each and every moment I chose. And I started off as a hospice volunteer, and for some reason they saw something in me and would give me like the most challenging cases. And because I was in this, skilled, trained, but kind of like a la-la land, like I got to do everything I wanted to do. And, it was really, really great. I just want to emphasize the importance of us all, taking care of ourselves, because I again do have a tendency of encountering difficult cases that can somehow be turned around, but it's very, very, very important that we all take care of ourselves, and even sometimes and maybe we can't all do that, but somehow take a step back, because when we allow any form of judgment or any attachment to the outcome, we are doing a disservice. And so I realized that because of the place I'm in now, right? I'm in the middle of a really challenging case. And I'm also going through some things in my own life. And so it has really been a learning lesson that, words are powerful, and something as small as saying, well, why is this room painted red, can really affect the energy in the room and how we show up for the people that we serve. And they don't need that. They didn't ask for it. We're the professionals. We need to know how to really take care of ourselves so that we're not vulnerable to the things that we know better. And the other thing I really want to stress, having, dealing with a palliative care team and thinking back when I first heard the word palliative, and it was like, what's that word? With my father, myself. And I'm like, what's that word? I never heard that. Is that people really do get the right to choose. They really get the right to choose. And when you continue to ask, send text messages, because as a professional, you think it should not be going that way. It's really unfair. And when we talk about people having that right, we really have to be conscious of how we show up. So if they say this is what we want to do and there's a frown, that kind of sends that person a message that, okay, maybe I shouldn't be doing that. Like, I applaud what you all have shared. I don't know if you did it on purpose or not, but I'm glad that you let his name slip out, because we should be saying his name, that he was a learning lesson, right? Like, he taught you all. We are learning from, Josh's story. And so I just wanted to put that out there, that I appreciate what you're doing. I know that pediatrics is not my thing. I would not be able to stabilize that environment and be the stronghold to be able to, I can't think of the right word, but to ground people. So I appreciate that, but I'm glad that you mentioned self-care, because I'm really learning it now, 6 years into doing this work, that, listen, when you're off balance, you're going to show up, and it could be a small thing, but it could be something critical for a person who is going through something. critical moment. And it could just be an eye or an eye look, or, you know, a roll of the eyes, or a little frown, or a laugh or a joke or something that doesn't sit right with them and makes them feel like everything that they're hoping for or dreaming for or working for is not the right thing. And so I bow down in gratitude for you sharing what you shared today.
Stacey and Karen, what do you think the future is? Do you feel like you're under-resourced in certain areas, or what's the future hold, or what does it look like? What do you think you need to keep it going?
More pediatric palliative care.
Yeah.
Practitioners.
Yeah.
Like across the state. Yes.
Yeah.
More
sounds that way.
Parents at home.
And more resources for parents at home.
Right. I guess that's what I was thinking, is that's a little slim. And even though they want to be home, this is so challenging. And we're seeing the same thing on the adult hospice side, is lack of ability to care for people at home due to everyone working or other pressures. Yeah.
Like inpatient hospice.
Yeah. Right.
Respite.
Right. Respite. Exactly.
Yeah. I think that I think we would all agree, right? That I think it's hard to, I think there's not enough practitioners, right? That are out there. Definitely not enough nurses, right? But I also think that there's not enough respite, right? And I think that's really a big thing, because I think it's hard because it's hard to have caregivers now, because I think most people work. So I think the concept of having the caregiver be totally the caregiver is a really hard ask now. Because I think most people who are being the caregiver are really, many people, at least in our world in pediatrics, and really in the adult world, I think it's really hard also, because I think a lot of people work. And I think it's a really hard ask these days to really have true hospice and or palliative care at home. So I think that we need to have a better workflow for both palliative care programs and hospice programs alike, you know. So we need to have like some great inpatient and great outpatient programs, like rethought somehow. And I'm not sure.
I agree.
You know, I don't know how it's going to work or how it will look, but I think that it would revamp the whole insurance system if we figured it out.
No, I agree. I think what we're seeing, at least in the adults too, is some families, nothing against nursing homes, but having some unfortunate experiences in nursing homes and now feeling they need to protect, and some of these were younger people, protect them, not keep them out of those situations if possible, just due to, after COVID and everything, staffing has been challenging. So even the place where you may have respite is kind of scary for you.
Yeah, and I think that, and I think that in the pediatric world, we don't have enough home care nurses. We don't have anywhere for even like short-term or long-term anything. And we don't have the nursing home situation in pediatrics doesn't really, we don't really have it.
Right, exactly.
There are only like two places in the state of New Jersey that we have long-term beds. They're very few that are kind of like what you would think of as a nursing home. And it's very few and far between. And the acute rehab situation in pediatrics is really quick, and it's a really quick turnover. So we don't have anything. We used to have some inpatient hospice beds for peds, which Ellen and I used to do for a while, and they were really great, but it didn't work financially. And I wish that it did, because it really worked. And it was a great concept. And, but again, I mean, I think that, I don't know. I mean, I'm not sure.
Yeah. And I think too, the hardest part is that the family becomes the caretaker. So, they're 24/7 taking care of the child, and they can't really be the parent sometimes because they're doing all the care at home. And we've had, luckily here, we've had some of our families that can't do hospice at home, they do come back and stay here on our oncology floor for some of our oncology patients.
You know, and we've been able to do it, but
right, I don't know how much longer.
I don't know. You know, I don't know that all the hospitals can do it or all the hospitals are able to do it. But we're able to do it. But I think that, again, I mean, you know.
Yeah, it's.
And I think that it's just not a doable thing.
You know,
it's just going through the grieving process. The families are exhausted. The parents, you know, everybody's exhausted.
And I think the difference between adult and pediatric, like when it comes to that, is that I think when it comes to hospice, if you think of it, I think you know, hospice in adults, I would say probably the average time frame of adult hospice is usually about 3 weeks, maybe. You know, we've had kids in the hospital on end of life anywhere from a week up to 4 or 5 weeks.
Yeah, that I can see that. Mm-hmm. Yeah.
And I mean, it could be draining for parents.
Mm-hmm.
You know, so you know, and I mean, it definitely helps to be in the hospital and you could be the parent and we have the nurses on the floor, you know, and, you know, the two of us can kind of tweak everything and, you know, but I think that it's just hard.
Dr. Rifkin, you mentioned earlier that there's a, you know, there's not a lot of practitioner when it comes to palliative care for, you know, for peds. You know, and
I can tell you in the state of New Jersey, there is about approximately about half a dozen of us that are board certified.
Well, how do you think that, you know, the schools or academia can help? Because I can imagine that there's a lot of like newly graduate nurse practitioners or pediatric nurse practitioners can help. Like if we partner with, you know, like schools, nurse practitioner schools to see if there are any people who are interested to go into this kind of specialty. Is there any kind of school or, you know, like preparation that they can go into, like certification that they can go into? Well,
I mean, the thing is that, I mean, from a pediatric, I mean, the thing is that for pediatrics, from a doctor standpoint, there's about 6 of us in the state, but nobody, the 6 of us that are in the state that are board certified are scattered in the state. Not all of us practice palliative care though. Some do, you know, medically complex. Some of us aren't practicing, but are boarded. So there's about 6 of us. As for the nurse practitioners that actually have done it, the ones that we know about, there's not many that have done pediatric palliative care. There's probably about a half a dozen in the state that I know of that have done it. I mean, most of the palliative care pediatric palliative care nurse practitioners have started doing it because they've worked with the physicians that that's how they started.
Or you know, have worked in ICUs, have worked in oncology, have worked in ERs.
Yeah,
I mean, because you really, you know, there's a wide range of things you have to know in order to, you know, we have kids that are medically complex that run the gamut of equipment that they have, medicines that they're on. So
usually the palliative care nurse practitioners kind of are the same as the doctors in the sense that most of the people in the state doctor wise are either there's 3 of us who are hematologist oncologists. There's 1 pediatric intensive care unit doctor. There's a pediatrician. That's 5 of us. Oh no, there's 4 actually. There's 4 of us that are pediatric hematologist oncologists. There's 1 intensivist and there's 1 pediatrician. So that's 6 of us. Yeah, there's 6 of us that are board certified. And then, I mean, it's the same as the nurse practitioners that I know of. It's like Karyl has worked in, you know, burn ICU, intensive care, like emergency room. You know, most of the nurse practitioners kind of are subspecialized also. Like they've worked in NICU, ICU, like that. Like they've worked in most of the subspecialties that they worked at. You know, so that's how they kind of got involved in palliative care. I don't know how to get people interested in it.
I think that Sheila Pandy, the president of the New York chapter of HPNA, actually mentioned when I introduced her to this lecture that she said, I'll send it to my pediatric palliative care students. So I think there might be something in New York going on that, you know, there is some education starting up there, but you know, as far as you're asking, Melissa, that's really the only thing that I've heard, but I definitely know she was mentioning her pediatric palliative care students.
So I'm not sure down at, you know, like, for instance, I don't know if at Rutgers in their School of Nursing, if they have a pediatric palliative care class. I mean, that would probably be the best, you know, group to kind of approach if anybody is really interested. I know that Karyl, you know, has a lot of nurse practitioner students, a lot of nursing students, a lot of masters of nursing students that rotate with us, you know, and we try to kind of recruit them.
Yeah. We myself and another APN, that's surgical APN, we do a lot of acute care APN students. So, you know, they rotate to it. And then, you know, some of the nurses that are in peds oncology or ICU may have a thought about doing that, but I think, I don't know, I don't know anybody that specifically says I want to go to school to be a palliative care APN or a hospice APN. And peds, the ones that I've come
especially pediatric. I mean, it's like,
I mean, really in pediatrics, I think, you know, we kind of, especially with the chronic kids, we do palliative care, whether it's under the term of palliative care, especially for like a lot of our long-term chronic kids. You know, if you're in the ICU or you're on the floor and you take care of these kids a lot of time, they are providing palliative care to the children and the families.
Because I think that, you know, if you think about the fact that we're doing an interdisciplinary approach, you know, one of the things that we do in, you know, just in hematology oncology, one of the things that it is, you know, is essential for pediatric hemonc is the fact that we do an interdisciplinary approach for pediatric hematology oncology. You know, if you ever come up to the floor at, you know, up here at Hackensack, I can tell you, because I've been on the hemonc service this week, because I do it a few weeks, you know, a year, about 6 weeks a year, I'm on service for hemonc. So there's about 15 people on rounds with me, because I have myself, my hemonc fellow is with me. I have a nurse practitioner who's my inpatient nurse practitioner for hemonc. Then I have 2 or 3 residents. Then I have my hemonc nutritionist. Then I have 1 or 2 social workers who are hemonc social workers. And then I have a child life person who's our hemonc person on the floor. And then I have the nurses who come on it. Like there's like 1,000 people. So it's like an interdisciplinary approach, like as we go along, you know, and it's like rounds. So I think that that's like the essential like model,
which is pretty much pediatrics, because we're very interdisciplinary.
Yeah, it's interdisciplinary. So it's like I always think of myself as part of a team when I do things. So that's why it's there's no I, you know?
I think we always work with that.
Yeah.
And then for two, like, you know, the word palliative care for families, they automatically think hospice or their child's dying. So we explain it's multi-complex. But another thing is we also do, our service does all the pain management in the pediatric hospital. So often we meet families early by doing pain management.
A known caller.
You know, so our families do know us, and if it transitioned into end of life care or need to start having goals of care, they already know us and have a relationship with us from a pain management standpoint, or we do symptom management also, not just for end of life, but for a lot of our patients, we do pain and symptom management.
I want to give everybody a chance to say thank you so very much for you guys coming on. I don't I want to respect everybody's time. It is 7:30, and you know.
Hello.
Yeah.
Can I ask one question? I was at work and I'm just leaving, so I couldn't chime in. Is that okay?
Yeah, of course. Yes, definitely.
Oh, thank you. My name is Rachel. I was kind of like in and out of this because I'm actually an RN. I work on the acute care unit, pediatrics at NYU. And I'm in PMP school right now. And I am interested in palliative care pediatrics. I'm doing a specialty sequence in the subject at NYU in their master's program.
Yay. Excellent.
So my question is, and I heard you guys just talking about that, but I was kind of like in and out because I was still at work. My question is, I guess, I know there are very few fellowships for it throughout the country. The most well-known one is in Boston. And I don't know, like, do you find it absolutely necessary to do a fellowship in order to work in the field? Because I know it is so specialized. I've spent a lot of time with our NP for, sorry, I'm running to the bus. I've spent a lot of time with our palliative care NP. I don't know if you know her, Julia McBee. But I've done clinicals with her, and thank you. And so she did the Boston Fellowship and thought that it had like a lot of value to her time. So I didn't know if like that's just like a very big life change to like move and stuff. So I didn't know like what your take on that was.
So I think that my take is that do I think that it would look good on a resume? Sure, I think it would look good on a resume, but do I think is it absolutely necessary? No, I don't think it's necessary. I think that if you really want to work in the field, I think that you would definitely get a position, because I think that if everyone, if you're interested and you really want to work in the field, I think that people are looking for somebody who, for somebody in pediatric palliative care. I think that it's great to have done that fellowship. And I think, yes, I think that absolutely it is a mecca for pediatric palliative care. And I think that they have a great program there. And definitely you would get a great experience, but is it absolutely necessary? I don't think so.
No, and like I didn't do a fellowship, and I've had a lot of experience in different areas of peds and stuff. But I think it's the team, and we work as a team. So I learned a lot from Stacey, from Dr. Rifkin.
And I learned a lot from Karyl.
And I learned from our social worker and our child life and our nutritionist, because we really work as a team. And I think also with all our subspecialists, I know them from the ER, so there's just a lot of collaboration. And I think that's where you learn. So
I'm going to give a shout out, and I don't think anybody, Ellen Coughlin will tell you about this. I learned on the job training from our hospice unit I was at Newark Beth for many years, and there was a hospice unit there, and I had a lot of on-the-job training from the nurses there in our hospice unit that taught me a huge amount about treating children, because although you can learn it, you know, I didn't live it, and living it, and actually being at the bedside with nurses who had done it for so many years. And these were not pediatric nurses, okay? These were hospice nurses, and we had a unit that was 0 to 100, okay? So I would walk into the unit and there would be somebody in a jerry chair, but then my baby would be walking around with one of the nurses. So I would go to the baby, and I would learn about on-the-job training with the nurses. And yeah, I knew about doing pediatrics, and I knew from studying stuff and all of the policies about things and how to do things, but really sitting there and watching and seeing how it was done was a whole different thing.
Yeah, you know, Stace, it's Ellen. I think it's what Karyl said before. We learned so much from you, but the nurses, you know, was a great synergy. Mm-hmm. I did have to fight for that at Newark Beth. They didn't want us to do peds there, but we did it. I agree. I think that's where, you know, because of your willingness to jump in and always be available, that made them feel empowered to do it and knew they could call you and get through the night. We had, you know, the time we had two infants on that unit for quite a while, mm-hmm. Which was very unusual, but you're right. I think it's the power of the team.
Mm-hmm. But it was a great team. I mean, that I learned so much from them.
Okay, thank you guys so much for being here. This has been amazing. If anybody has any questions, you can find us on Nursing Network. You can post something to our site there. And again, thank you, ladies, so very much for being part of this and educating us. And there is some information in the chat about LNEC, pediatric LNEC courses, and HPNA does have a lot of pediatric palliative care education. So yeah, take a look, and thank you guys. Thank you so much for coming.
You're welcome. Thank you for having us.
Thank you
so much.
It's great. Thank you.
Bye. Have a good night.
Bye-bye.
Bye. All right, so guys, thank you so much for being here. If anybody has any questions, feel free to, you can post them in the chat or contact any one of us. I don't know, I guess you could, an email address is associated with our Nursing Network account. All right, anybody want to have any questions? You know, one of the things that I did think about though was the children of people who have sick children. You know, I don't have any children, but I could just imagine for the child of a parent who has a sick child, how hard that must be for the child and for the parent to kind of spread themselves, you know, between a sick kid and a not so sick kid.
Mm-hmm. Right, the siblings.
Yeah. But anyway, thank you so much for being here. And it was so nice to meet you all. And hopefully we'll see you at our next,
you'll see us again.
Educational event. Okay, bye.
Sometimes I think maybe these people aren't even here.
Maybe, or maybe they log on and they get, you know,
I can pick them
distracted. Oh yeah, that's true. You can.
Let's see.
Yeah.
Name. Put them waiting room.
Yeah. Oops. Am I doing it right? I am. There we go. So I didn't, is Ryan